Hi, everyone. Welcome. I am Heidi Edwards. I am the president and founder of Sisters Hope Foundation. We are a 501c3 approved nonprofit organization supporting people with ALSP around the world. Today's presentation, we have Andreas from Vigil, Dr. Jennifer Orthman Murphy from University of Pennsylvania, and we also have Dr. Wolfgang Kohler joining us. So now I'm going to hand the presentation over to Dr. Wolfgang Kohler.
Yeah, thank you very much, Heidi. So, well, I think we have plenty of time for our discussions. Just let me open this here. So, I think we have plenty of time for discussions, so we can go through some issues and some points. And I'd like to start not specifically with this one disease, but also set it into a context of adulthood leukodystrophies. So this is a more general view, because I think that sometimes this disease, ALSP, is widely underdiagnosed, and so it is into a context. We have to see it into a context of white matter changes in adulthood. So this would be interesting probably to see how we can approach a white matter disease in adulthood and see what are the criteria. So the leukodystrophies also in adulthood is not just one disease. This is a group of disease that currently probably 20 or 30 different kinds of diseases we all call leukodystrophy. Sometimes we are not sure, is this leukodystrophy or is it something which is related to vascular problems or neurodegenerative problems. So this is an open field currently in adulthood neurology. So we learn very much from these new ideas to categorize white matter diseases as a leukodystrophy, which is always genetic, with a genetic background. And this is in contrary to other white matter diseases that are acquired, for example, vascular white matter disease. This is very important because later on I'll give you an example why this is also very important in the context of the diagnosis of ALSP. So we have an impaired white matter development, which is not only the myelin, but also other white matter structures. And also I will show you an example for this later on. Most of these diseases are progressive diseases. Some of these diseases also have some metabolic defects or inborn errors of metabolism. For example, in the fatty acid metabolism, for example, adrenoleukodystrophy or oligosaccharides or organic acids. There are a lot of diseases that may affect also the white matter of the brain. So the prevalence is I think, unknown, but if you add all the various leukodystrophies in adulthood, we come up with a prevalence of these diseases, which is very close to that what we know from other acquired white matter diseases in adulthood neurology, for example, from multiple sclerosis patients. So it's much more frequent than previously expected. I think this is the dark number is really high in these diseases. So sometimes it's also very challenging in adulthood. For example, here give you an example in this family tree. There was one patient coming to our clinic with a diagnosis of multiple sclerosis. And well, they say, well, we had made a diagnosis of a chronic progressive multiple sclerosis. We tried all these treatments, nothing helps. It was still progressing. So could it be a multiple sclerosis? And the only thing what they did not do before that is just to ask for a family history. So it's so important sometimes to ask for family history. And it comes out when you're asking for the family history that his mother had a cervical myelopathy, which means that the mother is walking very badly. She had some spastic paraparesis, and this was said to be caused by some cervical spine abnormalities, which is in fact not the case actually. And then her sister has a hereditary spastic paraparesis, and there are other family members said to be a spastic paraparesis. There were young child in the age of 8 who died from meningitis. There are other in the family history, other people in early and later ages dying from meningitis, encephalitis. So this is if you look at this family tree, you immediately should know that this is a genetic disease in the background here. It's one disease. And this is a typical family tree of an X-linked disorder. And in this case, this was a typical family tree of a family with X-linked adrenal leukodystrophy. So what I want to say is it's so important in the care of a patient with spastic paraparesis or early onset dementia to have a very extensive family history examination, at least about 3 generations. So there's a whole bunch of things that you would do in this situation if you're suggesting a leukodystrophy. Of course, you have the clinical symptoms, you have the family history, but also you are looking at the MRI pattern of what you find in the MRI. Sometimes a certain MRI pattern is diagnostic for a certain disease, not always, but sometimes. So pattern recognition, which we all learned from Mario van der Knaap, is very crucial in a diagnosis. But then in the meantime, very early in the diagnostic process, we're using genetic testing. And this is also something which is very important. If you have the suggestion or the idea it could be a genetic disease, we should use genetic testing as early as possible. Yeah, and we currently not looking at a specific gene. We're not looking at leukodystrophy patterns. We usually do an exome sequencing in these patients. So we have this information right away early in the diagnostic process, and I think this is very important. So just to summarize this first part of my talk is that there are really good reasons for diagnosing early leukodystrophies. We have the chance for genetic counseling, which is extremely important for most of the families, most of the patients. We have the chance for prognostic considerations, even though we don't know for many of the diseases what is the natural history in detail. So this is why we have to have these registries, and we learn from the registries how the disease may progress if a certain constellation is present. What is the prognosis? This is something that the patient or family is really wants to know, of course. What is my prognosis? What can I expect from this disease? And this is very difficult sometimes for many of these diseases, especially also for ALSP. And of course, it's prerequisite for applying a certain therapeutic option that you have a correct diagnosis. So having a diagnosis is important for considering therapeutic options like stem cell therapy, enzyme replacement therapy, some other therapies that are out there, maybe on new therapies, which we probably learn today a little bit more about, or gene therapies. These are therapies that only will be applied if a diagnostic procedure is coming to a final solution, a final diagnosis. So now coming to this ALSP, well, this is a bit confusing because there are a lot of names on this disease. ALSP is one of the names, but also hereditary diffuse leukoencephalopathy with axonal spheroids, HDSLS, was used quite frequently, or still used in the literature as well. So all of these diseases may be named as CSF1R related leukoencephalopathies. What is that? So we are looking at this in these diseases as a specific cell which is more diseased than other cells in this disease, and we are looking specifically on this little cell here, which we called microglia. Yeah, but you can see it's a whole tissue, the brain tissue. And it's not only this cell. When this cell is ill or is diseased, all the other cells are also affected because it's a network in the brain. We call this glia, but the glia is also connected to the neurons with the long axons here. You see here oligodendrocytes, you see astrocytes, and the microglia. And the CSF1 receptor is only present on the microglia. So this is a very specific receptor on the surface of this cell, which is diseased in this case. So it is present in the adult brain. Yeah, it is expressed on this microglia. Here's an example of this cell. And this receptor is crucial for the proper function of the microglia. The microglia cell is a cell which is mainly something like immune system of the brain. Yeah, many people, or it's not long known because it's thought that the brain doesn't have any immune system, but it has an immune system. And these microglia cells are heavily mobile. They can walk through the brain and look, what is something wrong there? Can we repair something? Can I help something? So there are a lot of functions that are addressed with this little cell. So it's much more important than we thought previously. And you can imagine if there's a problem with this cell, that it may impact the whole brain. And this is one of the most important and very impressive thing that I have to say looking at this disease, because it's other diseases are more may have focal problems in the back or on the front, but in this disease, the whole brain is affected. And this also is expressed by a great variety of severe symptoms that may occur with this disease. So, but in the end, we think that is a rare disease with an adult dementing illness. We actually don't know the prevalence actually. Well, there is an estimation which is very high, but I don't know actually if this is really true. But as I already said, I think that many other diseases are said are diagnosed, or this disease is misdiagnosed as other diseases. There's, for example, as Parkinson's disease, or as a dementing illness of other cause, or sometimes even as a stroke-like disease. And I'll give you an example for this in a minute. It's autosomal dominant from its inheritance, and this is very important as well. So you can see here on the right side, if somebody has the defective gene here as a yellow dot, everybody who gets the gene in the children, everybody will be diseased. Will get the disease as well. So this is called dominant. Yeah. So this is a very aggressive gene that always causes the disease. But how the disease, what symptoms occur, this is very variable in this disease. So there may be, within the same family, there may be completely different symptoms occur. Also, the age of onset may be different within the same family. And we have even children that get this disease so very early on. But usually the mean onset of disease is around early 40s. Yeah. So, so it's an average age of diagnosis of 43 years. The symptoms that may occur are very variable. I already said that. We had quite a lot of behavioral changes. We had depression, early onset dementia, but very impressive is also, which is still not in the focus of the descriptions from my eyes, it's a little bit underdiagnosed, is apraxia. Apraxia is something which is really impressive in this disease. You never see that in other diseases. Yeah, it's misdiagnosed, for example, as language problems or walking problems, even walking problems. I know patients who are not able to walk a single step. Yeah. And they were diagnosed as having paraparesis or tetraparesis, apraxia, not apraxia, ataxia. Yeah. But then you just offer or say, well, can you stand and close your eyes and make like this? Absolutely fine. No ataxia, not at all. So what can we walk together? And I give him a little finger, just a little finger like this, and we walk properly. So apraxia is they just forget how to walk. People can just forget to speak. That's not a speech problem, it's apraxia. And this is a typical symptom of a whole brain involvement. And this is very consistent to what I said previously, that if the microglia, who's all over in the brain and patrolling to the brain, is affected, the whole brain is affected as well. So the function of the whole brain is not probably there, but motor is intact, coordination is intact, even the language is intact. People can understand what I'm saying, but they cannot bring out a word, yeah, because they forgot how to speak. And this is very impressive in my eyes. So we should also bring this forward, that patients may be a very dominant symptom that they have apraxia. But you can see here where you see a nervous system in a schematic nervous system with the brain on top and all the nerves in the arms and legs and the back, and you see all these symptoms that may occur from the involvement of the nervous system. So it's a broad involvement of the nervous system, and the many symptoms may occur. I don't want to mention these in detail. So one aspect is very important, namely that frequently, I think very frequently, this disease is misinterpreted as vascular encephalopathy, so a vascular disease. I can tell you that from a clinical neurologist, we see in the clinic every day, we have in the radiological department, we see pictures like this every day. Yeah, maybe 10 every day. So this is extremely frequent that you see MRI changes like this. And usually the radiologist as well, this is a typical picture of a vascular encephalopathy, because you see multifocal changes, You see holes in here, which is a tissue destruction, and you see diffusion deficits here in this special sequence here with these white dots. They are associated with vascular problems. But this also is a typical MRI with the typical characteristics of ALSP. So these two diagnoses from a radiological point of view may be very, very similar, maybe misinterpreted very frequently. For example, in this case here, in this publication, you see 3 cases. You see the similar pictures here, like I showed you in the previous picture. All of these patients came up with acute stroke-like episodes, right-sided hemiplegia. Here's a stroke-like episode on both sides and a transient left-sided hemiplegia. So there are typical signs of stroke-like episodes that really are misinterpreted, and all of these patients were ALSP patients. So the diagnosis is made, we have to consider other diagnoses. As I already said, primary progressive MS. We have to consider multiple sclerosis or Parkinson's disease. We have to consider frontotemporal dementia and also minor strokes. And we have to exclude the diagnosis in the diagnostic process. Then we look at the MRI, which is very characteristics, and then we can do the genetic testing. So when it comes to treatment, I just want to mention a few points because we have other talks. We go maybe more in detail. We have currently no approved treatment for FDA approved treatment. This is, of course, important, but we have a lot of symptomatic treatments that may ameliorate the symptoms, like antidepressants or anti-epileptic medications once seizures are present, or antibiotics if infections are present. So these medications should be considered as a relief of symptoms, but also physical therapy for those who have movement problems or muscle problems. Of course, patients frequently need psychological support, and the family, of course, need genetic counseling. And I think it's very important, this counseling and support, the family support, the supporting system is extremely important to help these patients in the family. They need caregivers, they need some advocacy. Organizations are very important, like Sisters Help in this case. And of course, medical professionals should be informed about the disease and how to take care of these patients to improve a little bit the quality of life. So bone marrow transplantation is a potential treatment for ALSP for probably some patients. I must say, we currently don't know what are the right patients for this indication. So this is experimental in the moment. So there are only, I think, 11 patients published with this treatment. So, but of course, in specialized centers, there will be a consideration of this treatment as well. And this is what I want to say. Thank you very much.
Jen Orthman Murphy. I am an assistant professor of neurology at University of Pennsylvania. Excited to be here today. Thank you for inviting me, Heidi. Basically, I'm going to overlap a little bit with what you just heard from Dr. Kohler and sort of expand upon it. I'm coming at this as an adult neurologist trained in neuroimmunology and MS. And over the course of training, wondered about the patients that didn't quite meet MS diagnosis and what you were supposed to do with that. And that has led me to ALSP. Shown here is a picture of microglia in the brain. You can see they're all throughout the brain, all those little dots, up to all sorts of things, interacting with things. We'll talk a little bit more about that. So I'm hoping in a few minutes to cover a lot of topics, some of which you've already heard, but essentially talk about why it's hard to diagnose people with ALSP. And I'll go back and forth between calling it ALSP just because it's shorter to say than CSF1R related leukoencephalopathy. So I'm just going to call it ALSP for now. And then how we need ongoing clinical collaborations and research collaborations to figure out what's actually happening across many different types of collaborations. And then how can we develop treatments? What do we need to know and what is possible? And it's actually a really exciting time right now because in the glia world where I do research, there are tools that exist that we can find out what these cells are doing, the specific cells at different times, both in health and disease, to start to answer these questions in different types of models. And then basically kind of lay the way for future research that I would like to do and like to work with others on. So to start off, we talked about ALSP and brain MRIs, but I always like to start off by thinking what white matter is, because that's what we're able to identify on the MRI in this disorder, which actually from the clinical neurology perspective and how people present is a little bit weird that this is a white matter disorder, at least as we come up with the diagnosis. And so white matter is white, that we see not on MRI, but on pathology, it's white because it's filled with fat. And fat is made by these amazing cells called oligodendrocytes that somehow are laid down over the course of your lifetime and make up to 50 myelin sheaths to make axons work better for various reasons. So essentially on a neuron shown here, an oligodendrocyte will lay down myelin sheaths and it actually completely reorganizes the underlying axon to be more efficient in sending a signal. And so what that means is on the broader scale, on MRIs, when we're looking at someone in front of us who has symptoms, we can use specific sequences to say that this is a normal brain MRI, or we have specific patterns associated with what may be the more common acquired disease, multiple sclerosis, that is actually can be a diagnosis of exclusion because we don't have specific biomarkers that tell us it's a clinical diagnosis. But it's an autoimmune disorder that for whatever reason that we don't understand targets oligodendrocytes. But a microgliopathy that we now understand is due to mutations in CSF1R also targets the white matter. So as I said, I'm trained in MS, but wanted to know about the small cohort of patients that didn't quite meet a criteria for that. And so when I started at Penn in 2018, I walked into a neurogenetics clinic where I could see patients with a genetic counselor where white matter referrals were basically about 3% of the cohort going there. And my referral criteria to come to me was if there's extensive white matter abnormality on imaging or clinical features that didn't quite meet the diagnosis of these more common disorders that we know how to diagnose, or there's a family history of leukodystrophy, and I didn't put here, but also HSP, because as you can see, there's sort of overlap with the genetic disorders. And so can we make a comprehensive care clinic that addresses this? And then I always send all the rare neuroinflammatory disorder workup as I do this to make sure we're not missing things. So what does that mean to have a comprehensive care clinic? So as you heard, it's genetic counseling. You need to have counseling for understanding what testing means, like learning genetics when you show up in clinic is no small feat. And then if you have a diagnosis or not, what that means based on how we're interpreting the data, it's not clear always. And then referral to support groups and disease foundations, as you heard from Dr. Kohler. And then what we can always do, no matter what, even if we don't come up with a diagnosis, is treat symptoms like seizures and tremors, anxiety, mood disorders, pain, spasticity, and sleep issues. And then we collaborate with specialists, physiatry, PTOT, urology, neuropsychology, palliative care, other medical specialties, depending on the type of leukodystrophy, and social work, because many of these end up, even in the adults and even in the MS world, so I basically just sort of latch on to that, need a lot of support, both of family, the caregivers, and the patient. And so I had the opportunity as a fellow to work with Ali Fatimi at KKI to learn how to do this, as well as Adeline Vanderver at CHOP. And because of that, when I started at Penn, I was able to become a site for the Myelin Disorders Biorepository Project, which is a biorepository effort that has thousands of enrolled families at this point. And also out of CHOP is this Global Leukodystrophy Initiative, which is basically this international collaborative way to develop clinical trial readiness for these rare disorders. And so anyone who comes to see me is offered the possibility to be a part of this cohort so that we can learn more. And so in my 3 years, we send, this is just sort of a summary of my cohort that I've analyzed so far. We've sent single gene testing, gene panels, and whole exome. And actually now I send whole genome if insurance covers it in a reasonable amount. I mean, basically every 6 months, my strategy changes based on what's available. But the testing considerations that I take are, what is the most comprehensive and cost-effective test that we can do? So, you know, as a resident, it was, you know, if you can imagine the exact pattern that this fits, you'll send that gene testing. But now we are able to think about this more broadly, and it doesn't have to fit a specific pattern, and then we might find the result. But also you have to think about what disorders you're going to miss based on the type of testing you're sending. So if there's a family history of a known disorder, then I'll zero in on that gene. But if there's not, I send more broad testing that's affordable. And honestly, things changed a lot when the leukodystrophy panel from Invitae became sponsored, because I could send that on to everybody. And the number of genes that they have sent with that has increased over time. And so we've learned a lot from this, as well as had many diagnostic dilemmas based on the variants of uncertain significance reported. And so of this cohort, nearly a quarter we found a genetic diagnosis. Not all, just as a side note, have been leukodystrophies. The majority then are uncertain, and the reasons that they're uncertain so far are either because it's reported as negative or they're variants of uncertain significance. So we need to learn more. There are pathogenic candidates in here for various reasons I won't talk about today, but undiagnosed is its own interesting topic. Or they could technically meet criteria for MS, and my testing doesn't rule it out. And so what do you do with this cohort? So that's also a different topic. But the most common ones that I have seen in this cohort are adrenoleukodystrophy, ALSP, and adult polyglucosan body disease, which is how I got to being interested in ALSP. So it makes me think, what are the challenges to diagnosing this? Because in 3 years, I've seen a lot of patients for a rare disorder. So why is it so hard to find it? If it was for these criteria, it didn't end up being so hard for me to find it. And I think it's just as you heard, that it's because the types of first symptoms are variable. And you've already heard this, so I won't go through all the details again, but it can be MS-like, Parkinson's-like, mood disorder-like, cognitive-like. The variable age of onset, it's usually in the 40s and 50s, but it doesn't have to be. And the more it's diagnosed, the more we're going to be able to fill in those details. And then once it's symptomatic, it can be rapidly progressive. So who are the people that are going to send the testing, or refer to the people that are going to send the testing? And I think this is important because these are the people that we need to educate about it, right? And so where patients can show up are at the neurologist, and not everybody is a general neurologist. There's also the MS doc, so that most of my referrals have come from my colleagues. The neurogenetic specialists, if you have it, a cognitive specialist, movement disorders, stroke specialists, as you've heard. If you have a known family history from the genetic counselors or the medical geneticist, the primary care doctor is going to know if a whole family, or a family practice doctor is going to know if a whole family is affected and has seen them for a long time. Maybe the psychiatrist or psychologist, urologist, physiatry, PTOT. I mean, these are questions we need to ask the community to find out who puts you in the right direction to get your diagnosis. I think this should be an expanding list. So from my perspective, because there are no approved disease modifying interventions, what do we need to answer? So we need to be able to identify it early, which we can do with genetic testing if we get you in, either if you have a known history, so before you have any symptoms, or as early as possible with hopefully few symptoms. And the way that we can learn how to do that is through natural history studies and understanding the basic pathogenesis of the disorder. And then the goal would be to develop a treatment that prevents formation of brain lesions. If we can just prevent it, then we're good, right? Then no problem, we don't have to have a session anymore. We also need to develop treatments that reverse damage in the brain, and that doesn't exist for any disorder. I've come to this as a basic science researcher trying to figure out how to fix the brain through remyelination. We need to develop those treatments. And so natural history studies, so you'll hear from Vigil Neurosciences that these collaborations and multi-center studies are the way that we're going to figure this out. I'm also excited to say that I just got found out about that my pilot study from the Global Leukodystrophy Initiative will be funded, and it will be, for basically a long-term ongoing for everyone that knows that they have a pathogenic mutation in CSF1R, and hopefully collaborating around the world. And it will include patient-reported outcome measures as well as telehealth evaluations, and it will be something that I will develop over time. This is essentially a pilot and the first step towards that. And so I'm just including my email so you can share with anybody if you want to send them our way. And then it'll be really important to develop international working groups of people that are researchers and clinicians, industry, coming at this, and foundations, the patient groups, to understand how do we need to solve this? What are the most important questions we need to answer first? And what are the missing pieces? And so now we're going to go into my imagination a little bit about what I think is going on based on the pathology in the white matter. So I'll introduce you to my cells, all my favorite guys. Okay, so in the blood vessel, so you've got blood vessels all throughout your brain. You've got innate immune cells and you have adaptive immune cells. So I'm just introducing them to you to know that they're variable, and it's actually much more complex than this. But it's the innate immune cells that are the guys that express CSF1R. And in the brain, as you've heard, the microglia are the resident immune innate cells. And they actually come from their own source. They're different than the bone marrow source of the peripheral circulating cells, but they also express CSF1R. Again, it's more complicated than this, but these are the basic features. Also in the brain are oligodendrocyte precursor cells, showing you here as OPCs. They are a lifelong resource of a progenitor cells that make oligodendrocytes. They probably do many other things. That's why we have them all throughout adulthood, but they are an available pool of cells that can make new oligodendrocytes if they're lost, and then therefore myelin. There's also astrocytes. I'm showing here astrocytes as a cloud because they touch everything. They get in everyone's business. The neuron, the oligodendrocyte, myelin, the OPCs, the microglia, they fill in all the empty space, and they help, and they interact with blood vessels and basically help coordinate everything that's happening. So how do brain lesions form in ALSP? We don't know. We know what is found on end-stage pathology. And so we know in the lesions that are most affected, there's loss of microglia. It's a survival factor that seems related to the function of CSF1R, but how did we get there? There's loss of oligodendrocytes and myelin. And as a result, there's damage to the myelinated axons, and you get axonal spheroids. Astrocytes become reactive, and they probably stay that way, but we don't know. They're sort of described on the pathology as bizarre astrocytes, but what that means, we don't know. Again, there's a whole field of looking at what reactive astrocytes mean and how to study them. And this is new, and the tools are now available to understand this. Does the blood-brain barrier open? I don't know. Do immune cells come in and cause damage? The lesions don't seem to have B and T cells from the adaptive immune system, but it's possible that macrophages and monocytes come in, or the perivascular macrophages that are there also expressing CSF1R are causing problems. Again, we don't know. And do they turn into nasty, Pac-Man that are chewing everything up? Or is that a good function that they're supposed to be doing? Again, we don't know. So as you heard, a bone marrow transplant has been shown to perhaps stabilize motor, cognitive, and MRI findings in a few patients reported. And so I'm just naming here that University of Minnesota and Mayo Clinic Jacksonville have this ongoing study where they evaluate patients for this treatment. And so it's something that we have to consider, but again, is experimental. But which compartment is it working in? Is it working on the peripheral immune compartment? that's more likely, I think, because what we know from animal models is that it's actually really hard for a bone marrow transplant to get macrophages into the brain. And so maybe at end stage disease, when you've lost microglia, that's possible, but I'm not sure we totally understand how it might be working. So my goal, which is also now funded in part by this pilot study from the Global Leukodystrophy Initiative, is that one step towards understanding the peripheral immune compartment is to develop a biomarker platform that you can just check from the peripheral blood. And so basically, I'm going to try to develop a peripheral innate immune cell assay. A small study has been done on a few patients prior to this to try to look for specific markers, but we don't actually know how things change over the lifespan. So this has to be done in parallel with the natural history study. And I'm going to use the platform that's been set up by Amit Bar-Or, who studies the peripheral immune cells in MS. So I basically am on the same floor with him, and I can use all their approaches and learn how to do that. And so the goal is to use the samples that I collect as part of this natural history study and through the Myelin Disorders Biorepository project. And this is the website I'm sharing because anybody can apply to be part of the Myelin Disorders Biorepository project through this website. And then it comes down to really understanding the pathogenesis of how all of these cells are interacting with each other in the brain. Shown here on the left is an image that I took of a living oligodendrocyte. It is made pink, which fits with the Sisters Hope colors. But I'll have to do this with the microglia. I just made it pink because I like pink. What we can do with these techniques called in vivo imaging is find out what happens in real time to cells when they're exposed to damage or when perhaps they're expressing these mutations. And so just shown here is imaging the same region of brain in a mouse where the oligodendrocytes are expressing GFP, and I can follow the fate of every single cell that are lost and replaced and define what remyelination is. And these are techniques that can be applied to understand what's happening to microglia. So here's an example of microglia. You can see why my little schematic of microglia look like that, because this is what they look like in the brain. And there's models where we can look at them directly. Microglia are the first responders in the brain. So what happens when they're affected over time? Shown here is a laser injury, and you can see all those processes immediately within minutes going over to that injury to find out what's going on and probably clean up the debris. It's a highly dynamic system that's interacting with all the other cells that are there, even though we can't see them with this experiment. And so you have to do approaches that look at the context of interacting with all the other cells, as well as what happens when you manipulate a single gene or the function of an individual cell. So I'm going to stop there because this is the future, and there's a lot of things that we need to do to answer those questions. And to say that I require a lot of help to have learned how to do this and to get there. And so that's a combination of my neurogenetics colleagues, my colleagues at Penn, and the people that have helped train me. So thank you.
Perfect. Yeah, thank you very much. My name is Andreas Meyer. I'm Senior Vice President for Clinical and Medical Sciences at Visual Neurosciences. And first and foremost, before I start, I want to thank the organizers to kind of make this a topic here and give me specifically also the opportunity to talk a little bit about like what we do at Visual Neuroscience and our ALSP program. And thanks to Jennifer and Wolfgang, I think my presentation will be a little bit easier as well, because there's a lot of groundwork is laid in terms of some of the key players in this disease. So maybe before I speak about our specific program, a little bit around Vigil Neuroscience. Vigil Neuroscience is a microglia-focused therapeutics company, and the company itself is fairly young. It's been founded a little less than 2 years ago, just went public earlier this year in January. But even though it's a young company, it has been founded with a very clear mission in mind, namely to treat rare and common neurodegenerative diseases by restoring the function and vigilance of microglia, the brain's sentinel immune cells. And in doing so, we understand ourselves as a precision medicine-based company, which means that we are trying to employ all the tools you, with modern neuroscience drug development, have at hand, meaning like looking at biomarkers, looking at like images from MRIs and other imaging modalities, and also trying to apply like modeling approaches to better understand and to also earlier understand like if we are on the right track. And we hope that with employing this approach, we have a greater probability of success to hopefully sooner than later being able to provide like meaningful therapies to patients and to their families and caregivers and everybody who is involved. So with this, maybe a few additional words around microglia. I mean, we have already heard that microglia does a lot of things and is important. As shown here on the left-hand side, you can see that microglia is indeed like involved in a whole lot of different processes relevant for like overall brain homeostasis and brain health. But for our therapeutic approach, it's specifically important to keep in mind that like microglia are sentinel immune cells, that they send and respond to damage signals. And that can mean a lot of different things. It can mean like bacteria, that can mean like debris from cells which have normally died, that can mean other kind of foreign intruders into the brain, which are being identified by the microglia. And then microglia is capable of organizing a signal-specific immune response and activate all the relevant kind of downstream processes to do so. Conversely, that also means that microglia dysfunction is a key driver of neurodegeneration and is associated and implicated like with several like rare and more common neurodegenerative disorders, and that includes ALSP as well. So with regard to our specific therapeutic approach at Vigil Neuroscience, we are currently deeply involved and engaged in developing therapies which target the TREM2 receptor. The TREM2 receptor, or also in long called triggering receptor expressed on myeloid cells number 2, is next to the CSF1R receptor, another key receptor, like richly expressed on microglia cells. And what it does, so one of its key functions is that it basically, once it's activated, it can trigger like microglia cells, which are somewhat homeostatic state, or as Wolfgang explained earlier, just kind of like without a specific purpose, wandering around in the brain and looking for something which is not okay, and to identify this. And by triggering like some of these foreign objects, they may kind of activate this TREM2 receptor, and then microglia cells become activated, neuroprotective, disease-associated microglia, which then specifically try to kind of resolve and remove the threat. And looking at the TREM2 receptor in a little bit more detail here on the right-hand side, you can see that if you basically slice a microglia cell, this up here is basically the space outside of the cell. This is the cell membrane, and then inside the cytoplasm, that's inside the microglia cell. And if the TREM2 receptor, which is this thing here, identifies or is triggered by something which shouldn't be there, what it does then, and that is important to keep in mind for the therapeutic approach, what happens then is that the TREM2 receptor triggers another activates another protein called DAP12, which is located around the cell membrane. And this DAP12 protein then recruits and activates the so-called spleen tyrosine kinase, or SYK, and that's here represented as the yellow bubble at the bottom. And this SYK inside the microglia cell then can trigger like a whole slew of different activities. Signaling pathways are being activated, which then enables the microglia cell to kind of, that's how they basically coordinate like this immune response. So now a few additional words on ALSP. We have already heard that, we can keep this short, that ALSP is a genetic disorder which is caused by a mutation in the CSF1R gene, and that as an autosomal dominant disease, there is a likelihood of passing on this genetic variance every like basically it's a 50% chance like for each child. And the CSF1R receptor, as it was mentioned, is a key receptor for microglia to basically keep microglia happy and healthy, as it's shown here like on the graphs on the right hand side. And if there is a mutation in the CSF1R gene, and the gene basically contains the information to produce this receptor protein, if, as shown here, the information contained in this gene has an error, basically the receptor protein looks not as it should be, and it becomes dysfunctional. And that ultimately means that the microglia cell itself is not happy and healthy anymore. And that over the longer term leads to ultimately like neurodegeneration, and that is kind of seen in the end in those findings, like Jennifer has shown in her presentation as well, like in the MRIs, for example. So now the question is like, why would we think that a therapy targeting a TREM2 receptor, like the other receptor on microglia, is actually a relevant approach for a disease which is caused by a mutation in the CSF1R gene? And just to recap, I said before, like the TREM2 receptor, once triggered, activates the DAP12 protein, and this in turn activates the SYK kinase. And if you see here on the right hand side, which depicts how the CSF1R receptor functions, you can see that also the CSF1R receptor ultimately, once activated, in turn activates the DAP12, and DAP12 again activates the SYK pathway. And while there is currently no real therapy, nothing available to fix hypofunction or dysfunctional CSF1R receptors, we believe that by basically increasing the activation of TREM2, since both receptors function throughout the same pathway, we basically can increase and somewhat compensate for what is missing with the lack of function in the CSR receptors. So maybe so much about the scientific approach we have, and with the remaining few slides I have, I just want to kind of specifically talk a little bit about our natural history study. So as Jennifer and Wolfgang pointed out, there is still a lot to learn in ALSP. There is still a great diagnostic uncertainty, and it is for patients, for physicians as well, like often difficult to identify like who is actually an ALSP patient. And one way of kind of solving this and kind of improving the knowledge is to conduct a natural history study. Natural history study ultimately means that patients, in this case with ALSP, can enroll in this study. There is no experimental therapy, or so it is just kind of an observation over time. And the purpose, the underlying purpose, is to really understand better, like how does ALSP present itself? how does it affect patients and caregivers over time, and also to kind of better understand like what are the key kind of symptoms like patients are experiencing, which would ultimately provide a benefit if we could kind of solve some of those. So that's kind of the real underlying purpose of such a natural history study. It certainly helps us as a company as well to better design our drug development program and tailor it more or less to what it needs to be and identify the right endpoints and kind of see like what the right trial duration is and those type of questions. But also like creating this type of data set that is also something which overall helps the entire field and is valuable to kind of increase the overall knowledge and understanding of ALSP. And with this, I just want to highlight that even though it can sometimes be burdensome to kind of take part in a natural history study, every patient is extremely important, like taking part in the study, because without this, the knowledge gap will stay and we will not be able to kind of address things, at least not as soon as we would hope. So every patient is extremely valuable. Every participation is extremely helpful, like for the entire field in this regard, since this is a new kind of just growing disease, which has not been overly recognized in the years past. And like with regard to our natural history study, which has been ongoing for a little while already, patients with a documentation of a CSF1R gene mutation and who are also diagnosed with either symptoms or have what we call like prodromal ALSP, who have like beginning changes in their MRIs already, those patients can take part in our natural history study. The natural history study is a global study. We have sites in Florida, California, and Colorado here in the US. One represented actually right in front of me. And we have a site in Canada. We have 2 sites in Germany, I said, and sites in Netherlands and in the UK. What we also do have is that, assuming that not everybody will be living close to a trial center or a trial site. So in the context of this study, what is available is a travel assistance program, meaning that if patients need like help with like booking a flight, if it's further away, if patients need like a hotel to stay, if their caregivers need a hotel to stay, like those type of things can be taken care of in order to allow patients to travel, to take part in the trial, but also to allow like these sites, which are indeed like the global centers of excellence for this specific disease, to kind of being able to see and treat those patients on an ongoing basis. Practically, this study is set up in a way that overall the expected duration, like maximum, is up to 25 months, which means that there will be approximately 5 study visits. So every 6 months, there's a study visit. And during those study visits at the site, we'll collect like blood samples, MRIs will be done, but also there will be like cognitive testing and other questionnaires like related to like quality of life and like the burden overall introduced. And we have like a questionnaire also in like for caregivers and individuals assisting ALSP patients. So just to kind of get the information on these aspects as well. As said, travel assistance is an option. And what I also want to mention in this context, because sometimes that is a concern for patients if they take part in this study, what happens if there's a therapeutic trial coming? Can I still kind of take part in this one? And like for our own program right now, which is the only industry-sponsored program right now in ALSP, we are planning, we are on track to start our therapeutic trial with our TREM2 receptor antibody, which is named VGL101, towards the end of this year. And patients participating in the natural history study are not precluded from taking part in the therapeutic trial. So just to kind of highlight that and point that out right away. And more information can be found like under alspstudy.com on the natural history study and our program in general. And then the last thing I want to mention, and Heidi has also, like we have a couple of cards here, I think, for this, that is our ALSP registry. So while the natural history study is only open to patients who have either symptoms or the disease is actually beginning, the ALSP registry is open to everybody who has CSF1R mutation, and it doesn't require visits at a site. It is set up in a way that there are, like, either through the Google Play Store or the iPhone App Store, there's an app, and the app will kind of take everybody through the registration process. And then what will happen is that every 3 months, there will be a kind of a questionnaire, a survey, which shouldn't take more than 30 minutes to complete. And this will then kind of be collected and kind of build like a larger database. And this again, like, is the hope to have, like, ultimately for helping us with the drug development, but also helping the field to kind of collect the data and kind of identify patients, which sometimes are not easy to be found. And the countries where the registry is currently up and running are the same countries where we have our natural history study, namely the US, Netherlands, and Germany. And I think that was the last slide I had. So with this, I would like to thank you for listening. And I think we have a little time. So if there are any questions, just let me know, or you can directly approach me. And I think, like, Heidi also can, like, with the registry, like, definitely we have a couple of more cards there I've seen. If there's any.
And he doesn't speak anymore. He hasn't spoke for about a year. So you think it's just that he doesn't know how to speak? It's just, like you say, it's just like, he doesn't speak at all.
I'm not sure. Shall I repeat the question? So, well, wait a minute. Yeah, I think we have to use this for the live stream.
My husband actually was diagnosed with ALSP. Actually, it was December of 2020, and he has progressively been getting worse. He doesn't speak any longer. And I guess I thought it was so strange that, like, he was fine and then he didn't speak at all. That's just normal. He forgets how to, he forgets, I think, sometimes how to eat. I think he forgets how to swallow sometimes. And it just seems like it went fast. And I know I talk to you often, Heidi. But I'm trying to keep up. I think it's just so fast.
So, yeah. Do you think you have the impression that he is understanding what you're saying?
Sometimes he does, sometimes he does not.
Sometimes not, yeah.
Yeah.
So I think with the progression of the disease is there are two things mixing up. The one is what I called previously the apraxia. This is mainly how it starts with. So in this phase, people will really understand what you are saying. That is maybe in the beginning of the disease, even though he is not able to speak as he spoke previously, but he was understanding everything. But over time, there's an overlap with a onset of a dementia, which then also the understanding affects, and so this is a mixture in the end. Yeah, and that's I think the progression of the disease you're talking about is sometimes very fast. Yeah, that's my experience as well. So we don't know why many people really deteriorate so quickly and others a little bit slower. So these are open questions that we want to ask with the natural history study as well. But this is not an experience which is unusual that you make.
And you made reference to the differences in family. My husband's sister, my sister-in-law, passed away when she was 44. She had gotten the disease, and there was about 2 years from diagnosis to the time that she died. Her, until the time of her death, she could understand everything that was going on. She could not speak either, but she could understand everything that was going on. So like you said, just in families, just the differences in the symptoms that they have, that they're not the same.
Yeah, there are really differences within the same families. It's hard to understand, but most likely your sister also had the same disease, probably.
Well, she did.
Yeah.
Yeah, she did. She did. My father-in-law undiagnosed, but in hindsight, just his symptoms, his behavior and everything, I would have said was the same thing also.
Yeah.
So.
Yeah. This is, I think, a major point, that it's not always one person in a family. It's most likely it's more persons over generations, and people don't know why this happens really. So this is really something that we should try to address with new treatments. I have a question for you, Andreas. Why do we think that activating TREM2 is also activating CSF1R, even though there are no cells there? Jen told us that the cells are gone widely. So which receptors are you enhancing? Is it an idea? Is it the leftover cells that take over the?
Right. I mean, that's yeah. I mean, it's with regard to. I mean, there's some good like preclinical research, like looking into kind of down-regulating like CSF1R, and you can kind of like look at this then from a TREM2 kind of perspective. But yeah, that's the idea. I mean, this is ultimately where we need to kind of run the therapeutic trial, which starts to identify how meaningful, how significant the therapeutic effect will be in that regard. That is something that's an experiment, that is a clinical trial. I think we need to run going forward. And
are there preclinical data that make you optimistic from animals or?
So I mean that, right. So like from what we have in terms of like preclinical data, also what have been published, I think there is a whole lot of reason to be optimistic, but ultimately like for the human situations, there are no like ideal models in that regard. So we ultimately need to go into the clinic and explore like what the clinical effects are of this mechanism.
I had a question about how do you know that 2 years for a natural history study is sufficient to gather, to catch people at a time when they're declining quickly? Or is that?
So like for our current in and exclusion criteria for the natural history study, we like the key right now is to kind of to learn and to better understand like how the disease progresses. And that means that right now we are looking for patients who already have symptoms, and also for patients who are probably just right at the cusp or at the beginning of the symptomatic ALSP, so to say. And to like what was just discussed before, there seem to be differences in the trajectories over time, like for some of those patients, and that is definitely something we need to and want to kind of learn more about and better understand. 2 years, I think, is like generally for a natural history study in a neurodegenerative disorder is probably a good period of time to assess like overall how disease progresses. And we think that with like this natural history study, we definitely will get a whole lot of information out of this. And also what needs to be kept in mind, so some patients will come in like at a later stage, others will come in at an earlier stage. And in the totality of the data set, then hopefully you will be able to kind of put together like a whole holistic picture. That's the idea. Yeah.
I think the reason I brought it up is in AMN, that, the tools we have to detect change require 2 years. So then we would, the natural history data has been much longer because of that problem, but it sounds different in this.
Yeah, that's a good point as well in terms of tools available. So we like in the natural history study, we have a combination of like imaging related like readouts. We have also like blood related and CSF related markers in the study. Plus we have the clinical readouts. And I mean, ultimately you often see different slopes like on different markers, but we think that by combining those, that we'll be able to identify like certain patterns and hopefully understand the ultimate trajectory better. Yeah.
One question I have is for Andreas also. So you stated that you have to be symptomatic and of course a carrier of the CSF1R gene. Who determines if you're symptomatic to be able to enter into this study? For example, there may be a patient that is newly diagnosed with the CSF1R mutation, possibly through the INVITE program. So they haven't been examined clinically yet. They contact trials@vigilneuro.com. And then what? What happens next? So they truly don't know. They may appear to be asymptomatic, but we haven't seen an MRI yet, so we don't know for sure.
So yeah, ultimately that determination would be made by like our investigators. As said, I think like the few like sites we have are the real kind of centers of excellence, like here in the Western Hemisphere, more or less. And I think that also like looking through like patients who have been enrolled in the natural history study already. So there are certainly often like these kind of borderline cases, but it ultimately comes down to the impression of the individual investigator who knows this disease far better than anybody else. And sometimes it's more like the subtle signs as well, kind of telling you that either this might still be a stable kind of stage or something has started moving. So this is something which I think is best left with the assessment of the investigator.
So if the patient feels that they are asymptomatic, but they don't know for sure, they can sign up to go to a site and see the doctor, and they'll determine if they can be part of the study.
Right. Yes. Yeah. That would be like what we call the screening visit. And that would ultimately determine if somebody meets the current criteria for the natural history study or if it's probably still too early. And I think you are right that sometimes patients may still feel okay, but if you do like a cognitive testing, you may find like subtle indications already. If you do an actual MRI, you may see that suddenly there are some initial findings already. Or the other way around. So this is really something where the patient needs to be seen by somebody who understands ALSP and then can make the determination if that's a good candidate. And if there are no symptoms yet, then like with regard to our program, then there is also the option to sign up for the app in the registry, just to kind of somewhat like help contributing to the ongoing research, like and being able to kind of put like any changes in like over time and to see like how the disease develops or if it manifests at a certain point in time. Because this is, I think, also something which was mentioned earlier. There's a great variability in the manifestation, and I don't think that is very well understood yet either. Like, and if there are any kind of predictors you can employ in order to determine when actual symptoms would occur. So that's another very interesting aspect. I think there's a lot to learn about.
Yes.
From what I understand, the CSF1R receptor has been mutant from day one, and yet this is an adult onset disorder. So the question can be phrased in a couple of ways. What protects the person from the negative effects of this throughout that lifetime? in your genetic studies, have you identified anyone who does have the mutation who remains symptom-free, like a genetic modifier?
Well, I think this is the absolute perfect question, which we don't have an answer in, because if we would have an answer, we would have a treatment probably. Yeah. So, Jan, what do you think? You will say something on it?
This is part of what makes this is the basis of understanding what the pathophysiology is, right? Why, as far as we can tell, there's normal development. So why would a mutation in a survival and proliferation gene present in adulthood? Which is why I think, and has been proposed by groups like David Hume, that maybe there are other epigenetic or environmental hits that sort of bring this on in adulthood, that just having a mutation in the microglia is not enough on its own. But that has, we have to show what they are to understand that better. In comparison, we have the autosomal recessive mutations in CSF1R that cause a childhood onset disease. So if you have a completely dysfunctional CSF1R, you have a much more severe and earlier onset disease. So something different is happening in ALSP with adult onset, presumably because that's when we know to diagnose it at this point. But that's exactly why I want to have, and we need to work together in many ways to have broader natural history studies to find out when changes happen on MRIs, when first symptoms develop, so that you can diagnose before anything happens, potentially. And I don't think we know when the first step happens.
But it's in fact really a strange situation which we have in many of the leukodystrophies. Why occurs inflammatory disease at age 8, always at age 6 to 8, and then later on, and why not directly right away? So, and why do we have a genetic defect that gives us symptoms late in adulthood? So it's these are really open questions, but they're so important questions to answer that this has major impact on the whole strategy, how we look upon the disease and how we treat the disease. Yeah. Yeah. So it's a very good question. You want to?
For a long time, my family has suffered with this disease for over 20 years. And just in 2013, we were told what we were dealing with. And now that I've founded the foundation and I've worked with many different families, we have found that what we were being told was that you will get this disease in your 40s or 50s and you'll die from it in that time frame. But I have met now over 3+ families where the parents only found out that they were carriers of this disease because their child in their 40s or 50s was diagnosed. So then they tested to see who was carrying this, and the parent in their late 70s, early 80s, they have no symptoms, but they carry the CSF1R mutation. So we are now finding that it's all over the place. It's not consistent with what we were told 10 years ago, that if you have it at this age, you will die, from it, and you won't become symptomatic later. You may become symptomatic in your 70s, or I know in some of the research that we've seen, and they say in your 30s, 30 to 70, but we do have 20-year-olds in their late 20s, 27, that have passed away from the disease. So, we don't know enough about it yet, but it's very broad. And that's why, again, like Jen said, we need to work together to figure this out.
Yeah, this is this one of the situations you described in this older gene carrier without symptoms. You may also imagine a younger gene carrier, let's say 20 years old, identified by genetic testing or family screening. What shall we do with this? Yeah. So we are in a situation that we see sometimes relatives of affected people who are younger. So how frequent do we have to test them, or an MRI? What can we do? What is the right point of time for any kind of treatment? Maybe stem cell treatment, which is currently the only available option. Maybe we have a new option in the near future that would be very helpful, at least if it's beneficial for the patients. But these are really open questions that we have, but these are so important questions, they affect the families. Yeah, so if we talk to the families and say, well, it's better to test everybody, and then we test, and then we have to say you've got a gene and he's 24 years of age, no symptoms, normal MRI. What shall we do with them? Yeah. What is the suggestion? So this has a major impact on quality of life, probably. Yeah, you always have this Damocles sword upon your head, and so these are open questions, and we need to answer this together. Yeah. More questions? Yeah.
Thank you. Also for Andreas, because you mentioned that the natural history data collection and the registry will also likely be beneficial for the whole field. So I was wondering if the data will also be made available for other researchers or patients themselves.
Very good question. Thank you very much. I was also wondering, because we have multiple registries, right?
Yeah, that's certainly the idea, not to kind of keep the data as a proprietary set. I mean, right now these studies are ongoing, but the aim is certainly to kind of make this ultimately available for the field as well. I mean, I think that's definitely something also, like where I mean, we all need to kind of collaborate, I think, to find something to help those patients with ALSP, and I don't think that it would be good for the field to kind of just have like one party. I said, like right now these things are ongoing, but these will be certainly like published in due time.
Yeah, Andreas, I'm very happy that you're saying this in this context here, because I think it's absolutely crucial that if patients or families agree to send her data to a registry, the data in this registry should be open for all researchers, for all other future research, even though they are sponsored by one company. Well, that's your decision, but the decision of the patient is to give their personal data, which should be available for other scientific research as well. We have the same situation, for example, in the Leukodystrophy, whereas one sponsor for registry, but this registry is open for everybody. So I think this is the right way that we can use. More questions? Donna, you have a question? No question at all? You want to? Yeah, okay.
I provide support group meetings every month for our ALSP patients, and we have a really great conversation, and we invite in industry and other people to discuss issues. One thing that has come up in our meeting was the word Parkinsonism, and I saw it on your slide, and I have lost 5 family members to the disease, and the 5th family member was the first one that the word Parkinsonism came up in the doctor's office, because I described a situation and the doctor said it's known as Parkinsonism. Would you explain to the patients and those that are watching what exactly is Parkinsonism? Because that is something that they really haven't heard of.
Well, Parkinsonism is the wrong word, actually, at least in in German neurology. I'm not quite sure how it is used in English or American language, but Parkinsonism is a word which is a side effect of medications that you use for schizophrenia or psychosis. There are long-term side effects, which we call Parkinsonism. We rather use the word Parkinson syndrome also, because Parkinson syndrome means that it looks like Parkinson, like morbus Parkinson, which is the disease Parkinson, and which is rigid, muscular. You have maybe some tremor and slow movements of the face, of the muscles in the face. So it's like a mask and so on, and the walking is changing like in elder people. You sometimes have it as a phenomenon which is associated with age. But if it occurs in earlier ages, we call it morbus Parkinson, and that is a brain disease which is related to disease of basal ganglia in the brain. But this is the symptoms. What is meant here in the context of ALSP is that the symptoms may be similar to what you see in Parkinson's disease. So slow movements, rigid movements, less movements of the face, facial muscles, and the speech is getting slower, not so loud. It's getting, the tone is getting down and so on, and the writing is getting smaller, things like that. So you see that's in Parkinson's disease. But here, it's not Parkinson's disease, it's Parkinson-like symptoms or Parkinson syndrome. Parkinsonism is occupied as a side effect of these neuroleptic drug medication.
When my husband talked to his neurologist in Green Bay, they said my husband's symptoms were in between Parkinson's and frontotemporal dementia. That's what they originally were going for, because he was probably, they said, carbon copy in between those, that's what his symptoms were. And then they sent us to Mayo, of course, and then we got more answers. But they said that's where his symptoms all lie, in between those two.
Yeah. Well, in the Parkinson's syndrome or Parkinson's-like disease in ALSP, are more addressing the motor problems, but this is in combination with the cognitive decline in these patients, as I already mentioned, and the cognitive decline is similar to what we see in frontotemporal dementia, which is also a separate disease with a genetic background and everything. So these are both of these diseases, Parkinson's and frontotemporal dementia, other diseases. We have to exclude them, as I mentioned in my talk. We have to be sure that this is not Parkinson, this is not frontotemporal dementia, but the symptoms may be very similar. Yeah.
And that's what, when you said that they misdiagnosed them, you go back and forth to doctor, until you get your genetic testing. And
yeah, this is one point we really will address, I think, because at least, or let's say, if there's the option for treatment, then we need to have better diagnostic tools. So we will also have information for outpatients clinic that are taking care of Parkinson's disease, they're taking care of frontotemporal dementia, they're taking care of multiple sclerosis, or outpatients clinics that are looking for people with minor strokes. So these are the main differential diagnoses, and we have to inform our colleagues that if there's something different, maybe they have the chance to look at this disease to make a proper diagnosis as early as possible. Yeah. I don't think that there's a treatment possible in late stages of the disease. Yeah. So we have to have an early diagnosis. Then we have all treatment options once they're there.
What do you consider late stage?
Yeah. See, this, what do I consider late stage? I would say the most important criteria for late stage is already present dementing illness. So if somebody has dementia already, I don't think this is reversible. For the motor symptoms, maybe. So motor symptoms, I would not hesitate to try a certain treatment, for example, even transplantation. But if somebody is completely demented, not able to do anything on his own, like everyday care, eating, whatever. So this is something that is I would consider late stage. So I think we can end this this session and have some more time for a coffee. But I would like to end the session with a more optimistic view. There is a treatment coming, which makes us very optimistic. There are more experiences in stem cell treatment, also for certain patients, and we all are much more aware of this disease than previously, and we have people who take care of all aspects that are so important to take care of the patients, like Sisters Hope and so on, and with this, I think with this optimistic view, I let you go for a coffee. Bye.